Good afternoon to all. I am Dr. Sudhakar. In the next few minutes, I will try to discuss the role of anti-segment OCT as a diagnostic tool in deep stromal fungal keratitis with endoexudates and with intact corneal epithelium. There is no financial disclosures for the content of this presentation, and these are the scope of my presentation. In the next few minutes, I will cover these things.
4 speakers left.
It's not moving. Coming to background, fungal keratitis is a devastating corneal infection which results in deeper infections leading to endoexudates, which is challenging for the diagnosis. So corneal scrapings are not possible because of the intact epithelium and deep-seated infections. But for the appropriate management, we have to differentiate fungal keratitis from the bacterial or herpetic keratouveitis. They might also present with endoexudates. So in these scenarios, anti-segment OCT is very useful non-invasive imaging technique to diagnose the fungal infections. The area of focus in anti-segment OCT is the interface between the endothelium and the endoexudate. Introduction, infectious keratitis is one of the important causes of the corneal blindness in our country, and there are many kind of pathogens causing the infective keratitis with various and complex manifestations. So early and rapid diagnosis is very important for the effective treatment. Traditionally, smears and cultures are the only way for the diagnosis, but these tests are invasive and it cannot be performed in deep-seated infections with intact corneal epithelium. So in recent years, these endothelial plaques caused by the infectious keratitis, whether it is bacterial or fungal or herpetic keratouveitis, has gradually attracted the attention of the ophthalmologist. So endothelial plaque is a characteristic sign in fungal keratitis, but it can also be seen in bacterial keratitis as well as herpetic keratouveitis. But the composition is different. In fungal keratitis, the endothelial plaque consists of the fungal hyphae, but in bacterial keratitis as well as herpetic keratouveitis, the endothelial plaques consisting of fibrin material as well as inflammatory cells. So in slit lamp, we can see the endothelial plaques, but we cannot differentiate whether it is bacterial, fungal, and difficult to delineate the margin between the endothelium and the endothelial plaques. So it is important to find other examination methods to evaluate these endothelial plaques. So this is the background for my study. The aim of the study is to evaluate the role of anti-segment OCT in diagnosing deep-seated fungal keratitis with endoexudates with intact corneal epithelium. Methodology. Total 67 patients were included in this study after institutional review approval, and AIOS2025 was performed in all the cases, and microbiological evaluation was done on endothelial exudative material by taking endoscrapings. The outcome measures are to correlate the wavy border in fungal keratitis with the planar border in bacterial keratitis. So wave sign is a tool for diagnosis in deep-seated corneal infections with endoexudates. These are the anti-segment OCT settings used to take the images. Results, so among the 67 cases, 43 cases were fungal keratitis and 27 cases are bacterial keratitis. And typical wave sign is seen in more than 90% of the cases of fungal keratitis, but in almost 100% of the cases, bacterial keratitis, planar surface or smoother surface is seen. Among the 67 cases, 52 are male and 15 are female, and injury with vegetative matter is seen in most of the cases of fungal keratitis, and idiopathic cases are in 9 cases. In 39 cases, that is more than 90% of the cases, unclear wavy border is seen between the endothelium and endothelial plaques, and smoother planar surface is seen between the junction in 24 cases. So a wave sign is a typical in case of fungal keratitis. So it is seen in between the junction between the endothelium and the endoexudate. Why there is a wave sign? In fungal keratitis, the fungal spread is from the stroma into the endothelium, that is into the anterior chamber, resulting in the damage to the endothelium and Descemet's membrane, resulting in disruption of the endothelium, so that the irregular wave sign can be seen. In bacterial keratitis, the inflammatory response is linear response, but we can see the endothelial plaque. That plaque is not consisting of the infective material, that is mainly of fibrinous material and inflammatory material. So coming to conclusion, anti-segment OCT has a potential role as a non-invasive diagnostic tool in detecting fungal infections with endothelial exudates with intact corneal epithelium. These are my references. Thank you.